Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures. Chimeric antigen receptor, CAR, T-cell therapy marks a paradigm shift in the treatment of hematologic malignancies, representing a personalized and powerful form of adoptive cell therapy, often referred to as a living drug. This therapeutic modality harnesses the patient's own immune system by genetically engineering T lymphocytes to express a synthetic receptor that recognizes and eliminates specific tumor-associated antigens. The implementation of this specialized therapy demands a complex logistical and clinical undertaking known as the vein-to-vein (V2VD) journey, which spans from the initial collection of the patient's cells via apheresis to the final post-infusion monitoring period. A thorough understanding of each step is essential for the multidisciplinary care team, as the V2VD timeline is a critical determinant of clinical efficacy, particularly for patients with aggressive diseases. This content provides a comprehensive, expert-level overview of the entire autologous CAR T-cell process, detailing critical stages such as rigorous patient evaluation, T-cell collection and handling, the multi-week ex vivo manufacturing and quality control phase, the mandatory role of lymphodepleting chemotherapy, LDC, to optimize the in vivo environment for cell expansion, and the intensive post-infusion management of acute toxicities like cytokine release syndrome, CRS, and immune effector cell-associated neurotoxicity syndrome, ICANS. The following learning objectives are designed to ensure mastery of the critical procedural and pharmacological elements of autologous chimeric antigen receptor T-cell therapy. First, a mechanistic understanding is essential. Explain the fundamental concept of the therapy as a living drug, including the structure of the chimeric antigen receptor and the mechanism by which it recognizes target cells through cytotoxic activity independent of major histocompatibility complex molecules. Next, it is important to outline the entire vein-to-vein journey, identifying the main stages from patient evaluation through post-infusion monitoring. It should be recognized that a prolonged vein-to-vein process is associated with poorer clinical outcomes. Patients must meet rigorous clinical, physiological, and logistical criteria to be considered eligible for this therapy. Pre-existing health conditions and prior lymphotoxic therapies can influence the success of manufacturing the therapy. The leukapheresis procedure, which involves collecting lymphocytes, requires high-flow vascular access and should include standard management strategies for potential complications such as citrate-induced hypocalcemia. It is also necessary to specify the washout periods for common lymphotoxic agents, such as corticosteroids and purine analogs like bendamustine and fludarabine, to ensure high-quality collection of T cells. The manufacturing process involves several key steps, including the activation of T cells, gene transduction using viral vectors, either retrovirus or lentivirus, and comprehensive quality control assays required for releasing the final product. The rationale behind lymphodepleting chemotherapy involves a precise mechanism. It enhances the expansion and persistence of CAR T cells by depleting endogenous lymphocytes and increasing the availability of homeostatic cytokines. Comparisons between standard lymphodepletion regimens, such as fludarabine combined with cyclophosphamide, and alternative regimens like bendamustine, should include details on dosing and timing relative to infusion, especially as specified for major FDA-approved CAR T-cell therapies. Recognizing and grading toxicities are crucial. This includes describing the clinical presentations, underlying pathophysiology, and applying the consensus grading criteria for cytokine release syndrome and neurotoxicity associated with immune effector cell therapies. Finally, pharmacologic management strategies must be prompt and tailored to the severity of toxicity. For severe cytokine release syndrome, interventions include tocilizumab and corticosteroids, whereas corticosteroids alone are used for neurotoxicity. All management strategies should aim to control toxicities effectively while maintaining the efficacy of the therapy. Chimeric antigen receptor, CAR, T-cell therapy signifies a major shift in treating hematologic cancers, moving beyond traditional chemotherapy and targeted drugs to utilize the patient's immune system as a treatment tool. This form of adoptive cell therapy is often called a living drug, a personalized approach developed by genetically modifying a patient's T-cells to target and destroy cancer cells. The process is complex, involving logistics and clinical steps, from collecting the patient's cells to infusing the engineered product, often known as the vein-to-vein timeline. How long this process takes and its management are crucial for effective treatment, making understanding each part vital for the care team. This educational module offers a detailed, expert-level overview of the entire autologous CAR T-cell therapy process, with a focus on the procedural and pharmacological aspects of apheresis and lymphodepleting chemotherapy. The structure of the chimeric antigen receptor is crucial to its function and generally consists of three main domains. The first is the extracellular antigen binding domain, which determines target specificity. This domain is most often a single-chain variable fragment derived from a monoclonal antibody that recognizes a specific surface antigen on tumor cells, such as CD19 on B-cell malignancies or B-cell maturation antigen on multiple myeloma cells. The second domain is the transmembrane domain, responsible for anchoring the receptor to the T-cell membrane and linking the extracellular and intracellular regions. The third domain is the intracellular signaling domain. When the receptor binds to an antigen, this domain transmits activation signals into the T-cell. All approved chimeric antigen receptor T-cell products are at least second generation, which means they contain a primary signaling domain that mimics the T-cell receptor signal and one co-stimulatory domain, such as CD28 or 4-1BB. This co-stimulation is vital for strong T-cell activation, proliferation, cytokine production, and persistence, all of which are necessary for a durable anti-tumor response. The autologous nature of the therapy is a defining feature. The process begins with collecting T-cells from the patient, which are then sent to a centralized manufacturing facility for genetic modification and expansion. After this ex vivo engineering phase, the final CAR T-cell product is cryopreserved and shipped back to the treatment center for infusion into the same patient. This creates a highly personalized, often one-time treatment designed to establish long-term immune surveillance against the patient's cancer. The time from vein to vein includes the entire logistical pathway involved in a patient's treatment with engineered chimeric antigen receptor T-cells. This pathway begins when T-cells are collected from the patient's vein through a process called apheresis and continues until these engineered cells are infused back into the patient's vein. This journey involves a highly coordinated sequence of clinical procedures and manufacturing steps. The total duration of this process can significantly influence patient outcomes. Overall, from the initial evaluation to the completion of the immediate monitoring period after infusion, the entire process can take approximately 3 months. The key stages of the process are as follows. First, patient evaluation and insurance approval. This involves a thorough screening process to confirm eligibility, which typically takes between 5 to 7 days. Following this, there is an insurance approval process that can last from 10 days up to over 4 weeks. Next is the apheresis, or T-cell collection, which is an outpatient procedure lasting 1 to 2 days to collect the patient's T-cells. The collected cells are then shipped to a laboratory for manufacturing. During this phase, the cells undergo ex vivo engineering, including genetic modification and expansion. This step is often the longest, usually taking between 2 to 6 weeks, depending on the specific product and manufacturing process. While the manufacturing is underway, some patients with aggressive disease may require bridging therapy to control tumor progression. Following this, patients receive lymphodepleting chemotherapy, which is a short course lasting 3 to 5 days. This treatment is administered immediately before the infusion to prepare the patient's body to accept the engineered CAR-T cells. The final step involves the infusion of the engineered cells, a relatively quick procedure that often lasts less than an hour. After infusion, intensive monitoring is necessary, typically for at least 30 days, to manage any acute toxicities. During this period, patients are required to remain near the treatment center to ensure close observation and prompt management of potential adverse effects. The duration of the V2VT is not just a logistical metric, but has become a key clinical factor. For patients with aggressive cancers like large B-cell lymphoma, LBCL, a longer V2VT is linked to worse outcomes. Data from real-world cases of patients treated with axicabtagene ciloleucel, axi-cel, show that a V2VT of 40 days or more results in significantly lower complete response rates and poorer overall survival compared to shorter periods. A longer V2VT often indicates a more aggressive disease, as these patients are more likely to need bridging therapy while waiting for manufacturing. This highlights the connection between manufacturing speed and treatment effectiveness, turning the V2VT process into a race against disease progression. Different commercial CAR-T cell products have varying median V2VT times, reflecting differences in their manufacturing processes and logistical chains. For example, analyses have shown that for LBCL, axi-cel has a median V2VT of approximately 27 to 31 days, whereas tisagenlecleucel, tisa-cel, has a longer median V2VT of around 45 to 48 days, and lisocabtagene maraleucel, liso-cel, is intermediate at approximately 36 days. These differences are clinically meaningful and can influence product selection and patient management strategies. The field of autologous CAR-T cell therapy has rapidly grown, with several products now approved by the U.S. Food and Drug Administration, FDA, for various hematologic cancers. These products differ in their molecular design, manufacturing process, and approved uses, which in turn affect their clinical profiles, including effectiveness and toxicity. The main targets for currently approved therapies are CD19, an antigen found on B-cell cancers, and BCMA, expressed on malignant plasma cells in multiple myeloma. A summary of these key products is provided in this table. The CAR-T cell therapy process begins with two fundamental steps: the meticulous selection of an appropriate patient and the successful collection of their T cells, which serve as the raw material for the treatment. This phase is governed by strict clinical criteria and procedural standards to ensure both patient safety and the quality of the starting cellular product. Not all patients with a qualifying malignancy are candidates for CAR-T cell therapy. The selection process is rigorous and conducted by a multidisciplinary committee, which assesses clinical, physiological, and logistical factors to determine a patient's suitability for this intensive treatment. The patient must have a diagnosis of a relapsed or refractory hematologic malignancy that aligns with a Food and Drug Administration approved indication for a specific chimeric antigen receptor T-cell product. For instance, this could include diffuse large B-cell lymphoma after 2 or more systemic therapy regimens or pediatric B-cell acute lymphoblastic leukemia in a second or subsequent relapse. The cancer cells of the patient need to express the target antigen of the intended chimeric antigen receptor T-cell product, such as CD19. Patients are required to have failed a specified number of previous lines of therapy as outlined in the product's labeling. Chimeric antigen receptor T-cell therapy is typically considered for patients with highly refractory disease who have exhausted conventional treatment options. Physiological criteria include the patient's overall physical fitness and organ function. An important consideration is the patient's performance status, which is typically evaluated using the Eastern Cooperative Oncology Group scale. Candidates generally need to have a performance status of 0 or 1, meaning they are fully ambulatory and capable of caring for themselves. This level of functioning is essential to withstand the potential toxicities associated with the therapy. In addition, patients undergo a comprehensive assessment of their major organ systems. There are minimum baseline requirements for cardiac, pulmonary, renal, and hepatic functions that must be met. While these functions do not need to be entirely normal, they must be sufficient to tolerate the significant physiological stress related to treatments such as lymphodepletion and potential post-infusion toxicities, including cytokine release syndrome. A patient may be deemed ineligible due to several conditions. These include active and uncontrolled infections such as human immunodeficiency virus, hepatitis B, or hepatitis C. Additionally, primary central nervous system lymphoma is a disqualifying condition for most therapies directed at CD19. Patients who have previously undergone any form of chimeric antigen receptor T-cell therapy are also considered ineligible. Support for caregivers is essential for most programs, requiring a dedicated individual who can be available around the clock, especially during the initial period following infusion. This caregiver's responsibilities include monitoring for possible side effects, assisting with daily activities, and maintaining prompt communication with the medical team. Additionally, patients and their caregivers need to live within a specific distance from the treatment center, such as within 1 to 2 hours drive. This proximity is necessary for at least 4 weeks after the infusion to ensure thorough monitoring and quick response to any toxicities that may arise. The quality of the T-cells collected during apheresis directly reflects the patient's prior treatment history and overall immune health. Patients who have undergone multiple rounds of lymphotoxic chemotherapy often produce a starting cellular product with lower T-cell counts, diminished viability, and a less favorable phenotype, such as more exhausted T-cells. This can raise the risk of manufacturing failure and may be linked to worse clinical outcomes. Therefore, the apheresis product acts as a functional biopsy of the patient's immune capacity. This emphasizes the importance of referring eligible patients for CAR T-cell therapy earlier in their treatment journey, before their T-cell population becomes permanently damaged by successive chemotherapy lines. Leukapheresis is the standard procedure used to collect the necessary T-cells from a patient's peripheral blood. It is an extracorporeal process where blood is withdrawn, passed through an apheresis machine that separates and collects the mononuclear cell layer, containing lymphocytes and monocytes, and then returns the remaining blood components to the patient. The procedure requires high-flow vascular access to process a sufficient volume of blood. This is typically achieved through one of two methods. The first method involves peripheral access, where 2 large-bore intravenous catheters are inserted, one in each arm. One catheter is used for blood withdrawal, and the other for the return of blood. This approach is only feasible in patients who have adequate peripheral veins. The second method is using a central venous catheter for patients who have poor peripheral access. A temporary or tunneled large-bore central venous catheter, often a dialysis-grade catheter, is placed in a large central vein, such as the internal jugular or femoral vein. The placement of this line may be performed as a separate procedure on the day before the blood collection. The procedure duration and setting involve performing leukapheresis as an outpatient process. This typically takes place in a specialized apheresis unit or a blood donor center. The collection itself generally lasts between 4 and 6 hours. The primary goal is to gather a sufficient number of T-cells in a single session. However, if the initial cell yield is inadequate, the procedure may need to be repeated on a subsequent day. During the procedure, patients are closely monitored for potential adverse events. One of the most common complications encountered is a condition called hypocalcemia, which occurs due to the use of citrate as an anticoagulant in the apheresis circuit. Citrate works by binding to ionized calcium in the blood, effectively chelating it. This reduction in ionized calcium can cause symptoms such as numbness around the mouth and tingling sensations in the extremities. In more severe cases, patients may experience muscle spasms or tetany. To prevent or manage these symptoms proactively, healthcare providers typically administer calcium supplements, either orally or intravenously. The decision to provide supplements is based on the patient's symptoms and the protocols established by the healthcare facility. Apheresis collection facilities must adhere to stringent quality and safety standards established by accrediting bodies such as the Foundation for the Accreditation of Cellular Therapy, FACT, and the American Society for Apheresis, ASFA. These standards govern all aspects of the procedure, from donor suitability and equipment validation to product collection, labeling, and handling, ensuring the integrity and safety of the cellular product. The management of a patient's medications in the period leading up to leukapheresis is critical to obtaining a high-quality T-cell product. Unlike hematopoietic stem cell collection, where mobilizing agents like granulocyte colony-stimulating factor, GCSF, are used to drive stem cells into the peripheral blood, T-cell collection for CAR-T manufacturing is performed in a steady state, without such agents. The goal is to collect a representative sample of the patient's existing circulating T-cells. Many systemic therapies, especially cytotoxic chemotherapy and corticosteroids, are lymphotoxic and can severely deplete T-cell counts or impair their function. Collecting T-cells while a patient is under the influence of these agents can result in a poor quality apheresis product, which is a primary risk factor for subsequent manufacturing failure. To mitigate this risk, specific washout periods are required, during which these medications are held to allow for at least partial recovery of the T-cell population. The duration of these washout periods varies by drug, based on its half-life and its biological effect on lymphocytes. Table 2 provides a summary of recommended washout periods for common agents. The need for a washout period creates a significant clinical challenge. Patients with aggressive, rapidly progressing disease may not be able to safely discontinue all therapy for the required duration without risking significant clinical deterioration. This tension highlights the difficult balance clinicians must strike between preparing for an optimal apheresis collection and maintaining disease control. Furthermore, even after a successful apheresis, many of these patients will require bridging therapy to manage their disease during the multi-week manufacturing window. The choice of bridging agents must also be carefully considered to control the malignancy while minimizing further harm to the patient's residual immune system, which is needed to support the CAR-T cells after they are infused. This represents a complex clinical decision-making process that requires careful planning and coordination between the referring oncologist and the CAR-T treatment center. Once the leukapheresis procedure is finished, the collected mononuclear cell product is immediately processed and prepared for shipment. The cells are usually cryopreserved, frozen, in a controlled-rate freezer using a cryoprotectant solution, most commonly containing dimethyl sulfoxide, DMSO, to preserve cell viability during storage and transportation. The frozen product, carefully labeled with unique patient identifiers, is then placed in a specialized cryogenic shipping container, a dewar, that maintains ultra-low temperatures. This container is shipped by a dedicated courier to the centralized manufacturing facility, which may be located across the country or even internationally. This step marks the end of the first vein part of the journey and the start of the ex vivo manufacturing phase. The manufacturing phase is a highly sophisticated, multi-week process conducted under strict good manufacturing practice, GMP, conditions. It is during this ex vivo phase that the patient's own T-cells are transformed into a potent, targeted anti-cancer therapy. The specific steps and technologies used can vary between different commercial products, and these variations directly influence the characteristics of the final, living drug. Upon arrival at the manufacturing facility, the cryopreserved apheresis product is thawed, and the process of creating CAR-T cells begins. The initial step involves isolating and enriching T cells, also known as CD3-positive cells, from the diverse mixture of peripheral blood mononuclear cells collected during apheresis. This process is typically carried out using immunomagnetic selection techniques. During this procedure, it may also be necessary to deplete other cell types, such as monocytes, which can sometimes hinder T cell growth in culture. The purity and composition of this T-cell population are critical quality attributes, as they can significantly influence the entire manufacturing process. In their resting state, T-cells are not receptive to genetic modification. Therefore, they must first be activated. This activation process mimics the natural signals that T-cells receive when they encounter an antigen. In a manufacturing setting, The most common method for activating T cells in a polyclonal manner involves using immunomagnetic beads coated with antibodies against CD3 and CD28 markers. These beads provide the two essential signals required for T cell activation and proliferation. Additionally, monitoring changes in cell volume serves as a critical indicator of the activation status of the T cells. Once activated, the T cells are prepared for genetic modification. This process involves transduction, where a viral vector delivers the gene encoding the chimeric antigen receptor into the T cell's DNA. This integration guarantees that the CAR gene is consistently expressed and passed on to all daughter cells as the T cells divide. The two main types of viral vectors used for FDA-approved CAR T cell products are gamma-retroviruses and lentiviruses. Gamma-retroviral vectors, used in the manufacture of products like Yescarta, axicabtagene ciloleucel, and Tecartus, brexicabtagene autoleucel, can only insert their genetic material into the genome of actively dividing cells. Historically, there were concerns about their potential for insertional mutagenesis, inadvertently activating an oncogene, due to a tendency to integrate near gene promoter regions. However, modern vector designs have greatly reduced this risk. Lentiviruses, a type of retrovirus, e.g., derived from HIV, are used in products like Kymria, tisagenlecleucel, Breyanzi, lisocabtagene maraleucel, Abecma, idacabtagene vicleucel, and Carvykti, ciltacabtagene autoleucel. A key advantage of lentiviral vectors is their ability to transduce both dividing and non-dividing cells, which can allow for the modification of more quiescent, less differentiated T cell subsets such as naive and memory stem cells. They also show a more random integration pattern across the genome, which is generally seen as reducing the risk of insertional mutagenesis compared to older gamma-retroviral vectors. After successful transduction, the relatively small number of newly created CAR T cells must be expanded into a large population sufficient for a therapeutic dose, often numbering in the hundreds of millions to billions of cells. This expansion phase is a critical step that typically lasts for 7 to 14 days. The CAR T cells are cultured in a sterile, controlled environment using specialized growth media. This media is supplemented with growth-promoting cytokines, most commonly interleukin-2, IL-2, IL-7, and IL-15. These cytokines provide signals for T cell survival, proliferation, and the development of a memory phenotype. Commercial-scale manufacturing has largely moved from traditional static culture flasks and bags to more advanced, automated, and closed-system bioreactors. These systems provide better control over the culture environment, e.g., pH, oxygen levels, nutrient supply, and reduce the risk of contamination, ensuring a more consistent and reproducible manufacturing process. Common types of bioreactors used for T-cell expansion include wave bioreactors, such as Biostat-RM, use a gentle, rocking motion to mix the cell culture, which improves gas and nutrient exchange without subjecting the cells to high shear stress. Stirred tank or bioreactors use an impeller for mixing and allow for precise control over culture parameters. Studies have shown that the agitation provided by stirred tank systems can lead to significantly higher cell densities and greater overall expansion of functional CAR T cells compared to static culture methods. The choices made during the manufacturing process, such as the activation method, the duration of the expansion culture, and the type of bioreactor used, are not merely logistical. They actively shape the final cellular product. There is a growing body of clinical evidence indicating that the phenotypic composition of the CAR T cell product is a key determinant of its clinical performance. Products that contain a higher proportion of less differentiated T cell subsets, such as naive T cells, TN, and central memory T cells, TCM, are associated with superior in vivo expansion, longer persistence, and more durable clinical responses. Conversely, prolonged ex vivo culture can drive T cells toward a more terminally differentiated and exhausted state, which may limit their long-term efficacy in the patient. For instance, manufacturing processes with shorter culture times, e.g., 24 hours versus 7 to 14 days, have been shown to better preserve these desirable memory phenotypes. This concept, where the manufacturing process itself sculpts the therapeutic potential of the final product, highlights why different commercial CAR T-cell therapies, even those targeting the same antigen, can exhibit distinct clinical profiles of efficacy and toxicity. The final steps of the manufacturing process involve preparing the genetically modified T-cells, known as CAR T-cells, for shipment and administration to patients. Once the desired number of these cells is reached, they are harvested from the bioreactor. After harvesting, the cells are washed thoroughly to remove any residual components from the manufacturing process, such as activation beads and culture medium. Following this purification, the cells are formulated into a final suspension at the appropriate concentration to ensure safety and effectiveness during infusion. Cryopreservation involves storing the final formulated product in infusion bags using a cryoprotectant solution, which typically contains dimethyl sulfoxide. This process enables long-term storage of the product and ensures that it remains viable for use later. It also facilitates the global shipping of the product from a centralized manufacturing facility back to the patient's treatment center, while preserving cell viability during transportation. Before the final product can be released for shipment and administration, it must undergo a comprehensive panel of quality control tests to ensure it meets predefined specifications for safety, purity, identity, and potency. These tests are a regulatory requirement and are non-negotiable. One essential test is sterility and endotoxin testing, which confirms the absence of bacterial, fungal, or endotoxin contamination. To verify that the product is intended for the correct patient, identity testing for autologous material is performed. Purity is assessed by measuring the percentage of T cells in the product that successfully express the chimeric antigen receptor on their surface, often using flow cytometry. Viability testing ensures that a high proportion of the cells are alive and intact, especially after a test thaw. Potency is evaluated through functional testing to demonstrate that the CAR T cells can recognize their target antigen and mount an effector response, such as killing target cells or producing cytokines in vitro. Additionally, a molecular assay is conducted to quantify the number of copies of the viral vector integrated into the genome of each cell. This is performed using droplet digital polymerase chain reaction and is an important safety parameter to monitor the risk of insertional mutagenesis. Only if the product passes all these release criteria is it considered suitable for infusion into the patient. After successfully manufacturing the CAR T-cell product, the focus shifts back to the patient for the final preparatory steps and therapy administration. This phase includes the potential use of bridging therapy, a mandatory course of lymphodepleting chemotherapy, and the infusion process itself. The manufacturing of an autologous CAR T-cell product is a lengthy process, often taking several weeks from apheresis to product release. For patients with aggressive, rapidly progressing malignancies such as DLBCL, this waiting period presents a significant risk of clinical deterioration. Without intervention, a patient's disease could progress to a point where they are no longer physically fit to receive the CAR T-cell infusion. To reduce this risk, bridging therapy may be given between apheresis and the start of lymphodepleting chemotherapy. The main goal of bridging therapy is not to cure the disease, but to keep it under control, manage symptoms, and maintain the patient's performance status, ensuring they remain eligible for the CAR T-cell infusion. The choice of bridging therapy varies depending on the individual patient, considering their specific disease, prior treatments, and overall clinical condition. Common options include low-dose chemotherapy, targeted therapies, or localized radiation therapy. Selecting agents carefully is essential to provide sufficient disease control while minimizing cumulative toxicity that could impair the patient's ability to tolerate subsequent lymphodepletion and CAR T-cell infusion. Lymphodepleting chemotherapy, LDC, is a mandatory and critical component of the CAR T-cell therapy regimen, administered in the days immediately preceding the CAR T-cell infusion. It is crucial to understand that the purpose of LDC is not to treat the underlying cancer. Rather, it is to condition the patient's body to create an optimal environment for the incoming CAR T-cells to survive, expand, and exert their anti-tumor effect. The key mechanisms by which lymphodepletion chemotherapy enhances chimeric antigen receptor T-cell therapy include several important processes. First, it temporarily reduces the number of the patient's own lymphocytes, such as T cells, B cells, and natural killer cells. This creates physical space within the lymphoid compartments, allowing the infused CAR-T cells to engraft and proliferate effectively. Secondly, lymphodepletion decreases the population of native immune cells that compete with the CAR-T cells for homeostatic cytokines like interleukin-7 and interleukin-15. These cytokines are crucial for the survival and expansion of T cells. By reducing the competing cells, lymphodepletion increases the availability of these cytokines, thereby supporting the growth and persistence of the infused CAR-T cells. Additionally, this process helps to deplete immunosuppressive cell populations, especially regulatory T cells, which can actively inhibit the function and expansion of CAR-T cells. The elimination of these suppressive cells enhances the overall immune response. Finally, chemotherapy-induced cell death leads to the release of endogenous inflammatory signals. These signals help to prime the immune environment, making it more receptive and responsive to CAR-T cell activation and function. Together, these mechanisms contribute to the improved effectiveness of CAR-T cell therapy facilitated by lymphodepletion. Clinical studies have unequivocally demonstrated the necessity of LDC. Patients who receive CAR-T cells without prior lymphodepletion show markedly inferior cell expansion and clinical responses. The standard of care LDC regimen for most CAR-T cell products is a combination of fludarabine and cyclophosphamide, flu/cy. The addition of the purine analog fludarabine to the alkylating agent cyclophosphamide was a pivotal development that significantly improved CAR-T cell expansion, persistence, and overall clinical outcomes compared to cyclophosphamide alone. The intensity of the LDC regimen represents a key therapeutic variable that can be modulated. While more intensive regimens, e.g., higher doses of cyclophosphamide, may lead to more profound lymphodepletion and potentially better CAR-T cell expansion and efficacy, they also carry a risk of increased and more prolonged myelosuppression and other toxicities. This creates a critical risk-benefit balance that must be considered for each patient. For instance, a fitter patient with high-risk disease might be a candidate for a standard or more intensive LDC to maximize the chance of a durable response. In contrast, a more frail patient or one with borderline organ function might be considered for a dose-reduced or alternative regimen, such as bendamustine, used in some protocols for patients intolerant to fludarabine, to mitigate toxicity. Real-world data suggests that while bendamustine may be associated with lower rates of CRS and neurotoxicity, it may also result in lower response rates compared to standard flu/cy, highlighting the trade-off between safety and efficacy. This evolving understanding is moving the field toward more personalized LDC strategies rather than a one-size-fits-all approach. The specific dosing and timing of LDC are dictated by the particular CAR-T cell product and its approved indication. Adherence to these protocols is essential for both safety and efficacy. Table 3 in the notes section provides a summary of the standard LDC regimens for major FDA-approved products. The infusion of the CAR-T cell product marks the end point of the entire vein-to-vein process. Although the infusion itself is relatively short, the surrounding procedures are meticulous to ensure patient safety and product integrity. The final, cryopreserved CAR-T cell product arrives at the treatment center in a validated cryogenic container. Before administration, a strict chain of identity verification is carried out. Multiple healthcare professionals must independently confirm that the unique patient identifiers on the product bag and supporting documentation match the intended recipient. This step is crucial for safety to prevent the potentially disastrous error of administering an allogeneic product. About 30 to 60 minutes before the infusion, the patient is given pre-medications to lower the risk of immediate infusion-related reactions. The standard pre-medication includes acetaminophen and an H1 antihistamine, such as diphenhydramine. The prophylactic use of systemic corticosteroids is explicitly not advised, as it could interfere with the activation and effectiveness of the infused CAR-T cells. The frozen infusion bag is quickly thawed at the patient's bedside using a validated method, such as a 37 degrees Celsius water bath or a dry thaw device. The infusion needs to start promptly, usually within 30 minutes after thawing, because the cryoprotectant DMSO is toxic to cells at room temperature. The CAR T-cell suspension is administered intravenously, often by gravity, over 15 to 60 minutes, depending on the product and volume. It is crucial not to use a leukocyte-depleting filter, as this would remove the therapeutic T-cells from the product. During and immediately after the infusion, the patient is closely monitored for signs of an acute infusion reaction. DMSO can sometimes cause short-term side effects, such as a garlic-like taste or smell on the breath, nausea, or changes in vital signs like hypertension or bradycardia. These effects are usually mild and resolve on their own. After the infusion, the patient enters a critical post-infusion monitoring phase, where attention focuses on managing the expected and potentially severe toxicities of the therapy. The period following CAR T-cell infusion is characterized by intensive monitoring to detect and manage the unique and potentially life-threatening toxicities associated with this therapy. The activation and massive expansion of CAR T-cells in the patient's body, while essential for anti-tumor efficacy, can trigger a profound systemic inflammatory response. Understanding the pathophysiology, clinical presentation, and management of these toxicities is paramount for any healthcare professional involved in CAR T-cell therapy. The first 30 days after infusion are a critical window for the onset of acute toxicities. Regulatory bodies, through risk evaluation and mitigation strategy, REMS, programs, mandate strict monitoring protocols during this time. Patients are required to stay close to the certified treatment center, typically within a 1 to 2 hour travel distance, for a minimum of 4 weeks following the infusion. The first 1 to 2 weeks are usually spent as an inpatient, which allows for continuous observation and immediate intervention if necessary. Some treatment protocols enable outpatient administration and monitoring for patients considered lower risk. However, this approach necessitates a well-established infrastructure to support daily clinic visits and a highly engaged caregiver available around the clock. Daily assessments involve an intensive and multifaceted monitoring regimen. Vital signs are checked frequently, such as every 4 hours, to detect early signs of cytokine release syndrome, including fever, low blood pressure, rapid heart rate, or low oxygen levels. Laboratory tests are conducted daily through blood draws to monitor complete blood counts for signs of cytopenias, comprehensive metabolic panels to assess organ function and electrolyte imbalances, and inflammatory markers like C-reactive protein and ferritin, which are associated with the severity of cytokine release syndrome. Additionally, regular neurological assessments are performed multiple times per day to identify early signs of immune effector cell-associated neurotoxicity syndrome. These assessments include formal cognitive screenings using tools such as the immune effector cell-associated encephalopathy score. CRS is the most common acute toxicity of CAR T-cell therapy, occurring in the majority of patients to some degree. It represents the clinical manifestation of a systemic inflammatory response. CRS is initiated when infused CAR T-cells engage with their target antigen on tumor cells, leading to their activation and rapid proliferation. These activated CAR T-cells release a cascade of pro-inflammatory cytokines, such as interferon gamma, IFN-gamma, and tumor necrosis factor alpha, TNF-alpha. These initial cytokines then activate bystander immune cells, particularly monocytes and macrophages, which become a major source of additional key inflammatory mediators, most notably interleukin-6, IL-6, and interleukin-1, IL-1. This massive, uncontrolled release of cytokines, a cytokine storm, drives systemic inflammation, leading to increased vascular permeability, capillary leak, hypotension, and potentially multi-organ dysfunction. The cardinal sign of CRS is fever, typically defined as a temperature of 38 degrees Celsius, 100.4 degrees Fahrenheit, or higher. The onset of CRS usually occurs within the first week after infusion, with a median onset of 2 to 3 days for CD19-directed therapies. Clinical manifestations can range from mild, flu-like symptoms, e.g., myalgias, fatigue, headache, to a severe, life-threatening syndrome characterized by high-grade fever, refractory hypotension requiring vasopressor support, hypoxia requiring mechanical ventilation, and organ toxicities such as cardiac dysfunction or renal failure. The diagnosis of CRS is clinical, based on the characteristic signs and symptoms in the post-infusion setting after other causes, such as infection, have been considered. The severity of CRS is graded according to the consensus criteria developed by the American Society for Transplantation and Cellular Therapy, (STCT). This grading system is based on 3 key clinical parameters: fever, hypotension, and hypoxia, as detailed in Table 4. Management of cytokine release syndrome varies depending on the severity of the condition, with the primary goal of interrupting the inflammatory process while offering supportive care. For patients with mild symptoms, classified as Grade 1, management is mainly supportive and includes the administration of antipyretic medications such as acetaminophen and intravenous fluids. Close monitoring is essential to detect any signs of worsening. When symptoms progress to Grade 2, this indicates a critical threshold for intervention. In addition to supportive measures, treatment with tocilizumab, a monoclonal antibody targeting the interleukin-6 receptor, is initiated. Tocilizumab directly inhibits a key mediator involved in cytokine release syndrome. Patients with severe or life-threatening symptoms, classified as Grades 3 and 4, require intensive care management. These cases involve aggressive supportive care, which may include the use of multiple vasopressors to maintain blood pressure and mechanical ventilation to support breathing. Multiple doses of tocilizumab may be administered, and corticosteroids such as dexamethasone or methylprednisolone are added to produce broad immunosuppression. For cases that do not respond to tocilizumab and corticosteroids, other therapies targeting cytokines may be considered. These include agents such as the interleukin-1 receptor antagonist anakinra and the anti-interleukin-6 antibody ciltuximab. Immune effector cell-associated neurotoxicity syndrome is the second major acute toxicity associated with chimeric antigen receptor T-cell therapy. It is a complex neurological disorder that can occur with or without concurrent cytokine release syndrome. The exact mechanisms underlying this syndrome are still being studied, but they are believed to be different from those of cytokine release syndrome. The leading hypothesis suggests that systemic inflammation causes activation of endothelial cells and disrupts the blood-brain barrier. This disruption allows cytokines, and possibly the chimeric antigen receptor T cells themselves, to enter the central nervous system, leading to local inflammation and neurotoxicity. Cytokines such as interleukin-1 and granulocyte macrophage colony-stimulating factor, which are produced by myeloid cells, seem to play a more significant role in the pathophysiology of this neurological syndrome than interleukin-6. Clinical presentation of immune effector cell-associated neurotoxicity syndrome, or ICANS, manifests as a toxic encephalopathy characterized by a wide range of neurological symptoms. Early signs are often subtle and include difficulty with word finding, known as expressive aphasia, as well as deterioration in handwriting, called dysgraphia. As the condition progresses, patients may experience confusion, delirium, a decreased level of consciousness, tremors, and seizures. In its most severe form, this syndrome can lead to motor weakness, swelling of the brain known as cerebral edema, and potentially life-threatening increases in intracranial pressure. The onset of neurotoxicity typically occurs a few days after the development of cytokine release syndrome, but it can sometimes be delayed, appearing a week or more after the initial infusion. The diagnosis of this condition is primarily clinical and is made based on a thorough neurological examination. To standardize the grading of the severity of immune effector cell-associated neurotoxicity syndrome, the American Society for Transplantation and Cellular Therapy has established consensus criteria. These criteria utilize a simple, 10-point bedside assessment tool called the Immune Effector Cell-Associated Encephalopathy Score, which evaluates cognitive functions such as orientation, naming, following commands, writing, and attention. The overall grading of the neurotoxicity syndrome is determined by considering the score on this assessment alongside an evaluation of the patient's level of consciousness, the presence of seizures, motor function findings, and evidence of cerebral edema. These factors are detailed in the reference table from the notes. The management of immune effector cell-associated neurotoxicity syndrome involves a focus on corticosteroids. For patients with grade 1 symptoms, supportive care along with increased frequency of neurological monitoring is typically sufficient. In some cases, seizure prophylaxis using an agent like levetiracetam may be initiated. When symptoms are classified as grade 2 or higher, the primary treatment involves the prompt use of corticosteroids such as dexamethasone. Unlike the cytokine release syndrome, tocilizumab is generally considered ineffective for managing this neurotoxicity because it does not readily cross the blood-brain barrier and does not target the key cytokines involved in neurotoxicity. The management of both CRS and ICANS reveals a core tension in CAR T-cell therapy. The immune activation needed for the anti-tumor effect also causes these potentially fatal toxicities. The main treatments, especially corticosteroids, are immunosuppressive and may risk reducing the proliferation and persistence of CAR T-cells, possibly impairing their therapeutic effectiveness. Therefore, clinicians must carefully balance acting strongly enough to manage life-threatening toxicity without completely suppressing the desired anti-cancer immune response. The shift in management guidelines toward earlier intervention for moderate toxicities shows a growing consensus that short, targeted immunosuppression can enhance safety without significantly harming long-term efficacy. Beyond the acute toxicities of cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome, patients undergoing chimeric antigen receptor T-cell therapy are at risk for other significant complications, both in the short and long term. One such complication is prolonged cytopenias. Due to the effects of lymphodepleting chemotherapy and potentially the inflammatory environment, many patients experience extended periods of neutropenia, thrombocytopenia, and anemia, which can last for weeks or months after the infusion. These conditions significantly increase the risk of infections and bleeding. Another issue is B-cell aplasia and hypogammaglobulinemia. In therapies directed against CD19, the treatment causes the destruction of all CD19 expressing cells, including normal, healthy B cells. This effect, known as on-target, off-tumor action, results in B-cell aplasia and leads to low levels of immunoglobulins, or hypogammaglobulinemia. This condition greatly raises the patient's susceptibility to infections. Many patients require long-term, sometimes lifelong, replacement therapy with intravenous immunoglobulin to reduce this risk. Patients also face an increased risk of infections overall. The combination of lymphodepleting chemotherapy, prolonged cytopenias, hypogammaglobulinemia, and the use of immunosuppressive drugs to manage toxicity renders these patients profoundly immunocompromised. They are especially vulnerable to bacterial, viral, and fungal infections, particularly during the first few months following therapy. As part of post-infusion care, prophylactic antimicrobial medications are routinely administered to prevent these infections. Autologous CAR T-cell therapy has established itself as a transformative treatment modality for patients with relapsed and refractory hematologic malignancies, offering the potential for deep and durable remissions where few options previously existed. The successful implementation of this living drug depends on a complex, multi-stage, vein-to-vein process that demands meticulous coordination, specialized infrastructure, and deep clinical expertise. From patient selection and T-cell collection through sophisticated ex vivo manufacturing, lymphodepleting conditioning, and intensive post-infusion monitoring, each step is critical to achieving a successful clinical outcome. The complexity of chimeric antigen receptor T-cell therapy requires a highly integrated and multidisciplinary approach to patient care. Effective communication and seamless coordination among all stakeholders are crucial. A successful program in this area depends on collaboration among the referring community oncologist, the specialized T-cell treatment center, the blood collection unit, the cell therapy laboratory, and both inpatient and outpatient clinical teams. Clear communication channels are vital for managing patient referrals, coordinating medication washouts before the blood collection, planning for bridging therapy, and ensuring a smooth transition of care after treatment. Patient and caregiver education is also fundamental to the safety and effectiveness of this therapy. Patients and their designated caregivers need thorough education about the entire treatment process, including the significant time commitment and logistical requirements, such as remaining close to the treatment center for an extended period. It is especially important that they are trained to recognize early signs and symptoms of cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome, and are aware of the necessity to report these symptoms promptly to the clinical team. The field of chimeric antigen receptor T-cell therapy is rapidly evolving, with ongoing research aimed at overcoming current limitations and expanding the applicability of this powerful technology. One major challenge of autologous therapy is the lengthy, patient-specific manufacturing process that contributes to the extended period from treatment initiation to infusion, which can be problematic for patients experiencing rapidly progressing diseases. A promising alternative involves the development of allogeneic T-cells, which are derived from the T-cells of healthy donors. These can be manufactured in large batches, cryopreserved, and made available for immediate use, thus eliminating delays and variability associated with patient-specific products. An even more revolutionary approach seeks to bypass the need for ex vivo manufacturing altogether. Emerging technologies are exploring the use of delivery vehicles, such as targeted lipid nanoparticles carrying messenger RNA or viral vectors, to genetically modify T-cells directly within the patient's body. This in vivo strategy could significantly simplify the treatment process, reduce costs, and make T-cell therapy more accessible outside of specialized centers. Research continues to advance the design of the chimeric antigen receptor itself to improve efficacy and safety. This includes the development of armored receptors that are engineered to secrete beneficial cytokines, such as interleukin-12, to help overcome the immunosuppressive tumor microenvironment, especially in solid tumors. Simultaneously, safety-enhanced receptors are being designed with built-in kill switches or other regulatory mechanisms, allowing the cells to be rapidly depleted or inactivated in cases of severe, uncontrollable toxicity. These innovations aim to provide an additional layer of safety for patients. In conclusion, autologous CAR T-cell therapy has already changed the landscape of cancer treatment. As the technology continues to mature and these future innovations move from the laboratory to the clinic, cellular immunotherapy holds the promise of becoming an even more potent, safer, and more widely accessible tool in the fight against cancer. This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.